And we're just going to get started right away at 1 o'clock. As folks join, I'll just either admit them online or kind of usher them in to grab some lunch and join us. So thanks so much for coming today. I know how busy this part of the month and end of the year can be for all of us. So my name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children. I also moderate the Trainee Hub. We're just about to celebrate a year, which is so exciting, and we're excited to have you be a part of that journey. So our speaker today, who I'm very excited to introduce, is Jolene. She's the lead of Cohort Studies and Community Engagement for the Center on Drug Policy Evaluation, which is housed within the Lee Cushing Knowledge Institute at St. Mike's Hospital. She has roots in harm reduction and program management, going back to the downtown east side of Vancouver over a decade ago with the Portland Hotel Society and Insight. And Jolene's committed to serving populations that are substance using, marginalized, oppressed, with histories of homelessness and complex medical challenges, including HIV and hepatitis C. Safer opioid supply, safe consumption spaces, accessibility, community engagement, including centering those with lived and living experience, has really been the focus of Jolene's work within the community. So I'm very excited that she can join us today and lead us through her presentation. I won't take up much more time. I'm going to pass things over to Jolene to get the presentation started.
Thank you. I'm just going to stay here because we're such a small group. And that's why I feel like we can kind of engage and be a little bit more connected. So I'll stay here. We have a lot of stuff planned. We'll start with land acknowledgement. I'll do like a very, very brief introduction. Priscilla's pretty much told you what you need to know, where I come from. We'll run through the work that CDPE is currently doing. Then we'll take a break. Then for the second half, we'll talk about the Community Steering Committee. We'll talk about engaging respondents in community and improvements. We'll talk about engaging our partners in community and improvement. We'll talk a little bit about the surveys and compensation for the folks that we work with in community and why that's important. And then I've left some space for questions at the end. But what I was thinking is if people, and we are a really small group, so if people have questions as we go through, just popcorn style them out at me because I'd rather engage with people as we're going through. And other people might be kind of having similar questions or thoughts going through their heads. So just let me know. Stop me if something doesn't make sense. Stop me if you need clarification on anything. I know that different people have different sort of learning styles. So, all right. So I'm just going to kick us off with a bit of a land acknowledgement. So we at CDP acknowledge that we work and live on Treaty 13 territory, which was established between the Mississaugas of Credit River, the Anishinaabe Nation of the British Crown. We further acknowledge that we are surrounded by Treaty 13A, Treaty 20, also known as the Williams Treaty, and Treaty 19. We acknowledge the Wendat and Haudenosaunee people that also occupy this territory. This territory is the subject of the Dishwak Spoon Wampum Belt Covenant. This covenant was created between the Haudenosaunee Confederacy and the Anishinaabe Allied Nations to peacefully share and protect the resources around the Great Lakes. We wish to acknowledge that Indigenous and Black people, families, and communities are disproportionately targeted by drug criminalization, the toxic drug supply, and the war on people who use drugs. Further, that the philosophies of harm reduction and transformative justice are deeply rooted in Indigenous ethics and worldview. The work of harm reduction is inextricably linked to the work of unsettling, the work of decolonizing, and the work of racial justice. CDP acknowledges that we are all Treaty people. We shall honor and respect the past in order to move forward, sharing the visions of our ancestors, which thank you, all my relations. And I just also want to acknowledge the genocide happening in Palestine, Congo, Sudan, and other places around the world. And then before we kind of get moving, just from a social location perspective, I myself am a colonial white settler who is a cisgendered female in identity and identify as queer. My ancestors come from the formerly Nazi-occupied lands in Eastern Netherlands border in Germany. We were part of the Dutch resistance. My family identified as freedom fighters and survived the Dutch famine. So that's just a little bit about my background. And I hold all of our ancestors with great respect. for allowing us to share this time and space together. Okay. So at CDPE, we use scientific evidence about the impacts of drug policy on community health and safety. We produce high standard, peer review, scientific research studies, which we'll get a little bit more into kind of what that looks like of who we have identified as peers within the community. And we conduct outreach and knowledge translation on pressing current issues surrounding drugs and drug policy. We lead innovative primary research and implementation work around drug checking services, supervised consumption sites, overdose response, drug policy, safe supply, and harm reduction and prevention. Questions? We keep on sipping. Okay. So the sort of main study, or sort of like the biggest, the bloodline study that we have at the center is the Toronto Disparities Overdose and Treatment. It was formerly titled OASIS. The study's been going on for about 5 years. Our cohort is about, I want to say around 950, and we're capping it at 1150. So it's quite a large cohort. And we don't have, unlike other studies that go on and on, or sorry, that usually are capped to say like 6 months, a year, so forth. This study, we don't have an end date like for it yet. So the cohort is people who use drugs, looking at supervised consumption sites, drug checking, treatment, and the continuum of care. And then the 2 sub-studies off of that are IOT. So we look at the injectable IOT program, the injectable opioid and agonist treatment, and safer supply. So IOT participants are at the Works. So the Works is the only site currently in Toronto that is offering the service. And individuals who are on the program do pick up their medications between 2 to 5 times a day. So it is quite labor intensive for people that are wanting to be part of that program. And the survey for that focuses on the rationale for accessing IOT, specifics of treatment provision and the relevant outcomes. And then safe supply. Participants are prescribed at South Riverdale, Regent Park, Street Health, Moss Park, Parkdale Queen West. The other program that is also offering safe supply is Sherburne Health. So we'll also be interviewing people out of there. And the Intercity Family Health Substance Use Hub that's just down the street on Queen is also offering it. So we're also looking at interviewing people out of that space too. The survey focuses on the rationale for accessing safe supply, specifics of treatment provision, and any relevant outcomes. I wanted to talk a little bit about safe supply. Who in here is familiar with safe supply?
Are there any exclusions? I think that most of these treatments are pretty rare in pregnant people. But do you include? Yeah, you do. Yeah. Yes.
Yeah. I think I previously managed a safe supply program, so I can say that it was not the most common, but it was always an option. So at South Riverdale, for example, South Riverdale has the match team, which works with this midwife collective that works with pregnant people. And if they ever had people that were interested in safe supply, they would just get one purchase. Yeah. And then I can give one example that I'm very well aware of. The safe supply team worked with the hospital before the mother had gone in to work with the team there around what their plans were for sort of medication and titrations and pain management. When she was then and talked about any risks in that beforehand, as opposed to during, which would be really challenging, especially for labor. Yeah. Yeah. So if anybody's interested and they're pregnant, they wouldn't be turned away because they're pregnant. So, and I find safe supply in this last year or so has been controversial in the media for different reasons. And so I wanted to talk a little bit about what safe supply is and what safe supply is not, because I think that the sort of civil society, general population may not have a really good view of what it actually is. So safe supply is safer opioid supply, which is pharmaceutical opioid prescribed in community to individuals who are diagnosed with opioid use disorders. So you need to be diagnosed with a disorder in order to be part of the program. It's not just like there's like a big bowl of like dilaudid like Tic Tacs. That's not how it works. Initial prescribed doses of Cadian and dilaudid are based on the client's reported current daily fentanyl use and goals of care. People could also be using other forms, like there are people too that are using black market pharmaceuticals as well, and we wouldn't turn those people away. People could also be smoking as opposed to injecting, and those same things turned away. Cadian is typically used as a long-acting backbone to dilaudid in order to reduce withdrawal symptoms and cravings and avoid breakthrough withdrawal symptoms that might occur. And a client is receiving only immediate release hydromorphone. For opioid replacement, dilaudid is typically used by clients to obtain a euphoric effect. Though many clients also use dilaudid to manage withdrawal and cravings as an on-demand or on an as-needed basis. The choice to increase either the backbone, the SROM, or the immediate release hydromorphone should be based on assessment of the client's use, goals, and shared decision making. So usually the dilaudid would go up, and then the Cadian, they would sort of staircase that way. Urine drug screens are also part of the titration process, as are regular biweekly to weekly appointments with a community prescriber, sometimes more, sometimes less. Clients on safe supply are also connected to social workers, counseling, trauma support, community health workers, drop-in groups, harm reduction support, meal program, and specialty healthcare support. So they're not just receiving a prescription, they're also connected to quite a whole host of supports, which I think is part of the reason why people do not just the prescription. So national safer supply evaluation. So we are evaluating safe supply nationally across 11 sites. And we're also doing a GTA safe supply that's connected to TO. So there's two different ways that we're evaluating safe supply. So the safe supply pilot programs have been implemented across Canada to help prevent drug-related overdoses and other harms by reducing the necessity to rely on the volatile, unregulated street supply of drugs. This project is evaluating 11 SOS programs across Canada funded by Health Canada. We are looking at how programs are organized, participant characteristics, and program impacts in the context of the drug overdose poisoning in Canada. I know they're also interviewing staff and patients at the 11 sites across Canada as well. Like it's already underway, but wanting to get a sample of both to do that. And then shifting gears entirely, CDPE also has a policy impact unit, which looks at cannabis equity research, from research to policy. So using an integrated knowledge translation approach, makers, for example, policymakers, affected communities, civil society, inform research and outreach priorities, the current focus on cannabis equity and informing the legislative review of Canada's Cannabis Act builds on our first of its kind systemic assessment on industry inclusion and diversity. So this just came out within the last, I believe. So this is the new report and recommendations for achieving equity and social justice in Canadian cannabis policies. How can cannabis equity be pursued in Canada? So the first looks at inclusion of people from underrepresented racial groups and genders with a focus on people adversely affected by cannabis prohibition in the employment and economic opportunities emerging from the legal cannabis industry. Looking at amnesty for people with previous cannabis convictions. And the third is reinvestment of cannabis taxes into equity programs. So there's a much longer report, but this is sort of the three key pieces that it looks at. This speaks a little bit more to it. So the cannabis equity research NASLE worked with community in a variety of different settings to have input from underrepresented groups in the legal cannabis industry, namely Black and Indigenous people, as well as women and gender diverse folks. Provide input on our recommendations and strategies for cannabis in Canada, particularly around industry inclusion and diversity, for racialized steering committee members, providing feedback on recommendations around the reinvestment of cannabis tax revenues into communities most negatively impacted by prohibition, and members with past cannabis convictions, providing feedback on recommendations around cannabis, so how that actually takes shape. So the other piece is policy impact units, so work with the United Nations. So how this plays into my role whenever the United Nations does a call out for speakers, I usually share it with our community steering committee of folks with lived and lived experience, also with our community partners too to speak. So different times there's different topics where they're looking to speak. So it might be someone from a safe supply program, it might be a nurse practitioner that's providing, it might be somebody who is on safe supply, it might be something totally different, but I'll always share those call outs when they come. And NASLE again is our points person that works with the United Nations. So that includes providing input to member states and the United Nations bodies in support of evidence and human rights-based approaches to global drug policy. Serve on Canada's official delegations to UN meetings on drug policy, organize high-level UN events with member states and civil society. And NASLE chairs the New York NGO Committee on Drugs, a global umbrella organization with 100+ members that aims to support civil society or general society in engaging with the UN on international drug policy and practice. And, there's also policy impact. So usually this happens in Vienna in September. So the next call out will happen sometime in 2024. We're looking to have speakers from our steering committee attend as folks with lived and living experience and what their needs are. So in these cases, individuals would speak with lived or living experience to bring their perspective to high-level panels of policymakers, including the UN, and also providing input on events that highlight key issues or areas in international drug policymaking forums, most commonly at the UN Commission on Narcotic Drugs, which is a mouthful, in March, April, annually. So there's March, April, September.
Thinking that people are comfortable, like people with lived or living experience are comfortable speaking at events, and do you do anything to kind of prepare people and support them? Because that's something that I've been thinking about lately is like co-presenting, but I want to make sure that people feel like.
Yeah, usually what we'll do, so with the call out, when we let people know like, hey, this is happening, if anybody's interested, we'll support them in writing their abstracts or what they need to do. And I find there's different people, like I can think of the 15 folks that are on our steering committee, and some of them are already in advocacy roles within community and they're quite fluid in public speaking. And then there's other people who that is not their bag at all. You know, it's just not their jam. So I find it really varies. And I think that's why I really love our steering committee, because it's a blend of people doing different things in the community and who also bring different perspectives and different voices. So if you're planning to do something, doing like a co-design and co-led, I think would be great. And involving people along the way. But I think just like any body of people, some people are more comfortable speaking in public than other people. And it depends what you're talking about, right? Like drug use, for example, like drug use is something that's so intimate, and sharing what your habits and so on and so forth are with people is like a pretty intimate topic. So again, like it depends, I think it'll depend too on what the topic is. But lots of the panel that we have at CDPE are people that I've engaged with on like a safe supply panel and presented in different places, or that I've known over time. Like I've been living in Toronto and working in Toronto. So there's lots of different people on our steering committee that I've seen present over time at different places. Yeah. But I think obviously nurturing the connection and what you're preparing and presenting. You're making sure that they feel like comfortable in what they're doing and what they're talking about. Yeah, but I think it's fantastic. I think it's a great way to learn and share if people are open and comfortable talking about their experience and compensated. Which we'll get to that part a little bit later, but yeah. I also think breaking down the hierarchy between sort of like academic world and people that with lived and living experience is really important, especially and for learning, right? Like I don't think we can do better without having all perspectives at the table. Okay, so Primer 2 is another study. So this one looks at the ways that people help people who inject drugs to avoid providing injection drug use initiation that they don't want to. So it's looking at someone who is an injection drug user, has injection drug use knowledge, and looking at someone who isn't an injection drug user yet, but is seeking guidance to use by injection in a safe space. So it's looking at the relationship of those two people. It uses a treatment as prevention model, involves data from people who inject drugs across North America. So it looks at Toronto, so it looks at the TDOT study. It looks at data from Vancouver. It looks at data from Tijuana and San Diego. And the goal is to understand how people's transition from non-injection to injection drug use occurs and any reverse transitions too. So sometimes people are using by way of injection and then stop using by way of injection. So it also captures that data. The new frontier in research, pandemic preparedness. So this study looks at preventing morbidity and mortality among people who inject drugs in the post-pandemic era, modeling the impact of service restrictions during COVID-19 across 3 North American cities. 3 cohorts of people who inject drugs in settings impacted by overdose. So again, looking at Toronto, Vancouver, Tijuana, Mexico, and San Diego, US. So the aim is to identify setting-specific and shared correlations of overdose, COVID-19 infection, and morbidity, and evaluate the impact of COVID-related service closures and restrictions on people who inject drugs compared to the pre-pandemic. So I can say for Toronto, I mean, I didn't go anywhere for like 2020, 2021, but a lot of services closed down. I still went to work every single day during the pandemic. The safe injection sites were still open in Toronto, but I know that almost every other service that our folks were accessing was closed. Everything from mental health services to drop-in spaces to community food, that type of thing. Dynamically model the impact that maintaining service access during the pandemic would have had on the incidence of overdose, COVID-related infections and morbidity, and related health outcomes on people who use drugs by way of injection. Another area at CDPE is looking at clinical guidelines. So clinical guidelines for the management of drug dependence in Canada are generally based on the best available scientific data. One of the reasons that drug market patterns have shifted so quickly and clinicians and policymakers have responded with expert-driven guidelines rather than evidence-based guidelines. So I think looking at what is actually in our drugs, we've had to respond in a way that we can't wait for evidence because we're seeing the evidence of people dying. So Right now, our fentanyl that's being tested in Toronto is 1% fentanyl, and the rest of it is like a whole kitchen sink of other things. So it's not even fentanyl that people are using anymore, which is so. So the aims of the clinical guideline is to develop evidence-based guidelines for the management of drug dependence, ensure that these are up to date and reflective, systematically understanding of the evidence. And I think this is challenging too, because I feel like given the toxicity of the drug supply, the goalpost is sort of like ever changing to like you don't have a goalpost, it doesn't exist. And so if you're trying to come up with something that is evidence-based, it's really difficult when you're what you're looking at is continuing to change, even like from day to day to day. It makes it really challenging. So the systematic reviews, there is scientific and community consensus on the impact of certain drug policies on outcomes. Drug prohibition, drug law enforcement, and the criminalization of people who use drugs causes great harms. Too often, this evidence isn't been systematically gathered, which undermines policy reform efforts. So the aim of this is to identify topics that can be the most effective in ending the war on drugs and the drug toxicity crisis. Something else I thought about in that. I know in Toronto, I mean, I can speak to Toronto, but I think in 2021, the city was pretty close to moving towards a decriminalization motion. Just we're still, I know that it happened in BC, but I don't know that it happened in BC in a way that is necessarily benefiting drugs. I remain hopeful, but I also am curious as to where we're at and why it's actually. It's also not a perfect system because ultimately it will keep people out of jail or it'll keep people from having charges, but it's not going to change the drug supply. So until we actually look at regulation and legalization, that part of the market is still going to remain the same. The drug checking services. So the drug checking services was under CDPE until very recently. So the pilot for Toronto's drug checking services, which publicly reported on more than 11,000 samples between October 10th of 2019 and October 10th of 2023, was coordinated by CDPE. The Toronto Drug Checking Services now operates from its own site within the MAP Center for Urban Health Solutions at St. Michael's Hospital, a site of Unity Health. CDPE continues to work collaboratively with and conduct scientific research on the program. And on October 30th, 2023, funding was provided through Canada's Substance Use and Addictions Programming, also known as SUAP, and included money for Toronto's drug checking housed at St. Mike's Hospital and the emerging drug checking technology called Dose Check. So Dose Check is very exciting and much needed, but it is a handheld device that will be able to test samples and provide very accurate readings of what's in the drugs within 5 to 8 minutes. So it'll happen like right on site, which is great and it's needed. We still need a clean, untoxic supply of drugs as well, but at least it'll give people an idea of what's in the drugs. In the last 4 years, there have been over 400 different substances tested within the fentanyl samples that were not fentanyl, as I had talked about already. And as I also mentioned, the fentanyl presently being tested is 1%.
Sorry, so these substances, are these cutting substances or are they other drugs? Does it change? Okay.
It's like a kitchen sink. At 400, there's a lot. If you go onto the Toronto Drug Checking website, you can check and see, and it'll give you breakdowns of different. But it's pretty scary. Yeah, everything from like xylazine to traditional cutting substances that you would be in drugs to synthetic fentanyl to And of course, at that rate, if people are injecting these substances, then infection rates go up.
Like after people test their drugs, so say they find that it's like fentanyl and 4 other substances, I feel like this is where safe supply would work in tandem, right? And you could then take the contaminated and provide the safe option, but I'm guessing that would be too coordinated, right? So what typically happens after like drugs are tested and people find everything?
Right now it takes about 48 hours for people to get the results back. So for people who are needing to use it in that moment that are going through withdrawal, like it's going to be a whole different batch in 2 days by the time they get there. So we think the problem, right, is like the goalpost is ever changing, and just what's set up currently doesn't effectively address what the need is on the ground. Yeah, like it would be ideal. Like, okay, so this is me on a personal level. If I had the ideal, it would be somebody comes in, they test their drugs from the street. It has a range of substances, like various substances that they don't want, that they can actually trade it in for what they do want. I just don't know who's going to come back. So, yeah. And then some people, I mean, I think it depends too, is the person testing this, like, are they a recreational user? Are they planning to use this on the weekend? Are they dependent on this? Do they need to use it right now? Like, yeah, there's so many factors to consider. But a 1-for-1 program would be fantastic, and if we could get there, it would be. But that's me personally. I think it's time for a break, except for I don't know if we're really at like time for a break. Break was at like 1:45.
Yeah, so we're a bit ahead of schedule. I'm curious, is there anyone on the call or in this room who has any questions at this moment in time for Jolene? Before, because she has quite a bit planned on the next half of her presentation. I don't want to get too far ahead because you had mentioned you're going to return to this notion of compensation.
Yeah.
And how that piece works, which I know a lot of our trainees are quite interested in hearing how that works. I'm curious in terms of projects you've covered already, how you go about kind of recruiting those onto projects, your steering committee, and ensuring that they're supported through the process of their involvement and engagement.
Yeah. So part of the recruitment happened before I started, and then part of the recruitment has happened as I've joined. So I joined back in June of this year. But I've been working with CDP for 3 years while it's supply. So very familiar with all of our partners and community, very familiar with our population. I personally noted that there was some missing voices at the table that I really wanted to be at the table. We were also missing youth, which we had to kind of be considerate of. So the youth needed to be over 19 because we didn't want to have to get into like consent from parents that weren't supportive. So between 19 and 25, so that voice was missing from the table. A trans non-binary voice was missing from the table, which was important for me. And we were missing people from the prairie provinces. So we had good representation on the East Coast. We had good sort of Ontario, like north to south representation. We had good BC representation as well, but we had nobody from the prairie provinces. And I find that the prairies are a little different. They operate a little differently, and their harm reduction programs have had some different things that I really wanted someone in the community that on that location. So part of it was looking at what we had, and part of it was looking at what we needed. So that answers one of your questions, I think. We did in terms of like partnering. So for all of our 8 different studies that we have, we paired different steering committee members with those. So I put out a questionnaire for people and ask them what they were most interested in and what would be their top 3 priorities and who they would want to work with. And everything, like after doing a lot of kind of Tetris work, we paired as steering committee members with different research, the different projects. But we wanted to make sure people were interested. We didn't want to partner people with a study that they had absolutely no knowledge or no experience in or no interest. So yeah, so we did a like a poll.
There's a great deal of stigma and discrimination that goes hand in hand with the subject matter we're talking
Yeah.
about. And I'm curious how in this process of recruitment and onboarding and supporting members involved with projects in your steering committee, how you've navigated some of those conversations that take place pretty early on, I'm assuming, around those subject matters.
I think the partner aspect has been helpful because we've recruited through different partner agencies who support people who are using drugs. I'm thinking about just different facilitations or when we meet with our community steering committee. I think there's a certain level of openness and transparency when we meet with our folks. I personally come in with a background of lived experience, so I share that with people so that they know like that they can bring whatever they want up and they're not going to be judged for it. I guess the other piece is around taking their feedback seriously, or if something is tabled that we actually talk about it, we talk about it openly and together. And I think the feedback from our members is that they not only do they enjoy spending time with us talking about all of the various things that we talk about, but they feel like they can table things that don't sit or aren't sitting well with them in a way that they're not going to be judged for. So compensation has come up. And it was tabled, for example, that the compensation they felt, especially for doing review and peer review and the co-authorship and those pieces, that they should be getting compensated in the same way that a research assistant would be, for example. It should be. And we agreed, and so we changed it. Like it was that simple, as opposed to not being able to have conversations about things. I think even within the steering committee, right, there's people that are coming in at like a youth age all the way up to people that are like elders in that reduction. So it's a really interesting mix. And there are differences of opinion too on different things, even within the steering committee. I think respecting or creating a space where people can talk about their different perspectives within those meetings is really important, right? Because there's going to be people that in the broader community that associate with one, and there's going to be other people that jive with the other, and it doesn't mean that any one of those is any less valid than the other. They're both needed, like both of those perspectives are needed, for example. I don't know, does that answer your question?
Absolutely.
Yeah, I don't know, like, and I don't think that, I mean, in terms of like stigma, I think like stigma kills more people than anything else, but I don't think it's a conversation or a piece of work that just starts and stops. Like I think it's ongoing, and I want to say that I don't know when we'll see a day that stigma doesn't exist within healthcare systems, within civil society. I don't know. I'd love to see it, but I think it's something that's ongoing. It's something that's like to continuously be challenged. So that's the other thing is, as I think the staff at CDPE, including myself, I don't mind being challenged. I don't mind being challenged at all. Like I would rather have a challenging discussion where things might be uncomfortable for me, and actually hear someone out than not hear them out at all.
Yeah. Are there any other questions?
Yeah. I wonder about topic is drug use, and people can be like very traumatic, but they have to relive things, or it could be, I work in the area of pregnancy, so you know, if we start looking at like complications, you know, the perinatal period or neonatal outcomes, like just making sure they're not shame or the decisions they've made. So I don't know. I'm just wondering if there are ways that you are like mindful of like causing more harm to people by co-designing and co-creating things.
That's a good question.
There must be some, you know, there's going to be people who's fine to take on a role like this, but then maybe when you start talking through data and findings and stuff, then you know their feelings could change, or they could.
There's different biases too, right? Like I think whether it's conscious or unconscious that there's biases that come in. Pregnancy and drug use. There's lots of great resources, but I also wonder about touching base with different, like we'd be well tapped if we touch base with them now. But not because they're working for companies. Community. And I agree with you. I think that there are questions on there too that can, and there are good. I think one of the things too is asking yourself the question of why are you asking the question? Is it going to change the patient? Is it going to change the outcome of the baby, right? Like I think there's a lot of questions that get asked in medical settings that don't change the outcome for the patient, and they're so invasive. That will like why do you need to know that? Is it going to change something? You know?
I feel like as academics, though, sometimes we're so hopeful that like our research eventually becomes like that patient.
And even asking the person like what they need or what they're comfortable talking to you about, and it might not be. And I think it's relationship dependent too. Like, it may not be on the first appointment that you want to jump down someone's throat. But it might be something that you bring up once you have a bit of a rapport with the person actually feels comfortable. Yeah, I think I need like real specifics on like how to navigate a specific situation. People know, like people that I've had the great privilege of working with, like, they have a really good read on people and like what you know instinctually you're asking, or if you actually care about that person's well-being. And they'll call you out on it too, which is great, but that may not be the answer that you want because they might just put up a wall and not answer your question. Right, when you're trying to provide service or you're trying to provide care. I mean, yeah, giving people autonomy. I mean, I can say like work from a trauma-informed lens, but in practice, I think that's simple, like.
No. Just throwing out whatever's circulating in my mind right now.
But one thing I would ask, you know, and one thing that I do ask myself is like, yeah, it's more the question of like, what is the benefit of me knowing this, and do I need to know this right now? In this particular moment, you know, I know some care is provided where like, let's look at like an emergency department where you're seeing that person and they're eventually they're either going to be discharged or they're going to be admitted, right? So you're trying to gather as much information as possible. But if it's someone that you're going to have an ongoing relationship with for 9 months into delivery, like you have a bit of time to think about when you want to start laboring. The questions around care, and how that looks. I mean, I think about harm reduction in pregnancy too. It's like if someone came to me and was pregnant and they were looking for, you know, any kind of harm reduction stuff, I would, my concern would be to give them the harm reduction stuff so that they have to apply. Maybe on their second visit when they came back, I may talk to them about, you know, if there's anything else that they need. You know, see if they offer that they are pregnant, and then sort of build on the conversation from there. But if I'm providing harm reduction, and that's what they're coming in for, I'm providing harm reduction. So I think that also matters too, right? Like, what type of service are you providing this particular person? Yeah, it doesn't have anything.
No, there is something else you answer to that, but it's a good question for us to keep in mind. I think what we'll do in the moment is we'll take about a 5-minute break. And then we'll reconvene and keep going, if that's okay with everyone. So as people join, we'll just ease into the conversation. For those that are online, we're just resuming the rest of the presentation.
Sounds good. I guess the other piece too that I sort of slipped in was the knowledge translation piece on safe supplies. So that's also on the second half.
Perfect.
Yeah.
Learn about that piece.
Amazing. Yeah, I forgot that I had learning. Who was able to read the medical journal? Okay, because that will sort of inform the next pieces. So this article came out in October, which was last month, which honestly feels like last year. Like, I agree, there's so much going on, there's so much happening. So at CDPE, we have been exploring how to make medical journals and manuscripts accessible to broader audience in formats that are also accessible. Only 2% of the population reads and reviews medical journals, which does not support data getting into communities, as those who predominantly read medical journals are also already working within the medical. So generally, these really fabulous medical journals come out, they get shared in an echo chamber, and then they never actually make it into the hands of communities who are impacted by them. And I think that this has been a hot topic for us of how do we break things down so that people either want to go and read, or how can we condense it so that it's attractive to read or catchy when everything is like in social media land, and the way that information is shared right now. And we're also, as a human species, inundated with information every which way we go. So our cohort lead, which is me, and one of our cohort admin support, worked on a method to build lay summaries into one-pagers and support information graphics that are accessible. We also consider things too in the graphic layout of like visual accessibility and things like this too, not just how to make these more accessible. So this is too small for me to read, so I'm not even going to read it, but we came up with a process. There was a Instagram post that somebody had made back in July that shows you how you can create a summary with a MacBook. And it is fantastic. I can share it with Priscilla. I think I did share it with you. We're trying to figure it out on non-Apple. So for like PC users, it's not quite as good as on an Apple. Like the way that an Apple will deduce like a 15-page article into a lay summary is phenomenal. So we've created a one-pager. So this can be shared. And I mean, if this is shared broadly on social media, I would say that the likelihood, and this is just like me kind of speculating, like if something like this was shared with 10,000 people, I would say about 50% of them would read this, is kind of what I'm thinking. We also created challenges of safer supply programs during COVID-19. So we broke it down into 4 of the main things that this article looked at. So this is even breaking it down even smaller. So we looked at organizational features, pilot programs, outer context, intervention characteristics, and implementation process of the programs. We also looked at safe supply client outcomes. So clients enrolled in safer supply programs have increased time and stability. This allows people to engage in programming and services that address health and social well-being needs, such as housing and stability, employment, or doing volunteer work. So this, I mean, I'm going to go back to like my original 10,000 people. If I share this with 10,000 people, I'm pretty sure that like all of them are going to take that in right in that moment. And it's accessible and it's readable. And they'll be like, oh, now I want to know more about safe supply. And then the likelihood of them actually going to click on the full article and like reading through it is more likely than if I shared the medical article from the onset. Another graphic that we wrote down was sort of like a did you know? So clients in safer supply programs experience significantly improved clinical health outcomes like reduced ED visits, hospital stays, incident infections, substance use related deaths compared to those not accessing such services. So I think reading something like this, it's hard for me to put myself in like a civil society position because I've been doing this work for so long. But if I was someone that wasn't related or tethered or connected to harm reduction or patient outcomes or the population that I've been working with for 15 years, I would probably be curious, like, what is this safe supply? And the likelihood of me actually wanting to go and read the article would be also, I think, higher with something like this. So this is what we're looking at breaking down for all of our medical journals that actually come out is things that incrementally take large pieces of information into smaller, more knowledgeable, or sorry, not more knowledgeable, less knowledge, but really key points so that people will actually want to go read the information.
Do you run it through the program and then vet it by the steering committee?
So we run it through, so that we kind of did, so our process was interesting. So we used the cannabis one initially. So we used the cannabis work that had just come out and we ran it through the processor. And it gave us, the accuracy was 100% versus what was actually used. So we ran it through, so with the safe supply and the COVID-19 outcomes, we ran it through the processor and we went back to the person who wrote it and said, is this accurate of what you would have picked out as your lay summary? And sure enough, it was. And same with some of these smaller pieces. So I think at this point, we're using the technology that we have, but we're also checking to make sure that the information that we're sharing is goes through human beings as well to make sure that it's actually accurate. Yeah.
Clarify, so the program helps deduce the key pieces, but doesn't do the graphics and the images. So you do that piece.
Yeah.
So, okay.
But it pulls it out. So that article, I think, was like a 15-page article, if I'm not mistaken, because I'm an author. I remember it's quite cumbersome. But yeah, you run it through the processor and then it will give you a lay summary. And the interesting thing about it is that you can, there's like a little sort of like sliding scale kind of thing, and you can decrease how big your sentence is or increase it to bigger paragraphs. So you can kind of pick and choose, like, do I want that to be 2 sentences or 3 or 1? So it's really, really, really handy. We found, I was like, how could
What is this?
Yeah, I need to know.
it's right embedded into your computer. I'll share. Priscilla has the link to share it with you, but
That'll save me so much time.
I know this is just, and then you know your work, right? The thing is, like, from a research perspective, like, you will know your work, hopefully inside and out by the time you've written a 15-page, manuscript, that you'll know, okay, yeah, this is accurate. This feels like what I would have pulled out anyway.
It won't be like public stored somewhere, chat GPT or anything, which I like.
No,
Just
nope.
here.
It's not AI.
How do they not know?
Yeah. You set it up as a summary on your settings. and then you highlight your writing. And then I think you go back up to the top toolbar, click summary, and then it brings up this box, like it brings up like a little screen. And then, yeah, it's pretty magical. When I first saw it, I was like, how am I this old and I didn't know this? Mhm. So it's very, very cool. We were really excited. So I flagged Tanisha, who I work with, and I worked with Tanisha on Safe Supply, and she, working with her for some time, I know that knowledge translation is something that she's really passionate about, and she also did all the graphics, and I know how talented she is. So we just decided to do like a mini sample of it and work it out. And then we just started to move forward because I think this information about different outcomes around drugs, around like drug checking and stuff, like that kind of information needs to get out into the community quick, and it needs to be in a way that's visually appealing where people can consume it, you know, in a digestible, quick kind of. So. Okay. Before we move into this piece, I'll ask the question, or I'll propose the question of how would you engage an individual through research within community? This can also encompass the circle of care. So if you're not doing research and you're looking at things from a circle of care perspective, what are some things that you would do or consider to engage folks?
So what I did. Well, mine's a little bit different. First, I more had people. It's very good to direct questions and stuff, but I reached out to different like relevant organizations with MS Society. Different places. Typically, they all have like a research coordinator of some type for questions just like this, where people were looking. Some charge you. But they were like, as soon as they saw that I had ethics review, they were happy to send it to the parents. I just like Googled a bunch of like disability, and then I put together with the sales help like a one-page flyer and everything, and I just shared that. But I found it difficult. It took me a really long time. Super small guy, super great on it, which is fine for me. But if I was doing like qualitative research or something, that was what I did. But I was wondering if like your organization, if they ever open like their advisory group, or if they facilitate like engaging with people with experience, like disengaging people.
Yeah, we're gonna get into that. Yeah. That's the other half of my job. So I run the TDOT cohort, but the other half of my job is community engagement. So any of our work with our partners is something that I coordinate. And then also our community steering committee is also something that I run. Yeah. And I feel like in what you said around creating partnerships to create relationships in the community is quite important. Are there other thoughts?
Just to add on that, so like our lab, which is the Demar's lab, focus on like RB, which is rare pediatric eye cancer. And our supervisor, essentially like when creating the lab about 5 years ago, she had a parent with lived experience, and they joined the lab, her name's Ivana, and essentially with the patient or parent partner, they created an RB community, which is now known as the Canadian Retinoblastoma Board. And I guess like that's how it started. So like with a patient/parent partner who has lived experience, and then creating more engagement within the RB community. And now a lot of our projects have a patient partner side to it, where we deal with the patient partners and work alongside them, work with them on different projects, and that's what friends is doing.
Yeah, so just to expand on Omer's, it started off as Crab is it started off smaller, but through creating a space where families with a lived experience of retinoblastoma could come together, there was a lot more chance for creating connections and recruiting patient partners in that space. And so now we have 5 patient partners who work to varying degrees with our lab. One of our partners, Ivana, is actually in the lab, and then other ones consult and advise on different things. So that is kind of how we've started to expand and meet new people who have lived experience. But also, one thing we have been talking about lately is circle of care and recognizing all the different people that interact with families and patients, and how they are the people who actually know the patients that we would like to include in our research. And I say patients specific to pediatric eye cancer, not necessarily people who use drugs. So that is one thing that I'm curious to hear you speak about, because we've been talking a lot about how nurses spend a lot of time with patients, and they'll have a good sense about when it's appropriate to approach family if they're interested, depending on where in their treatment journey they are.
Yeah.
And things like that.
That's cool. So it started, so I just so that like, because this is very interesting. So it started with one particular parent that came in with lived and living experience, and then the program sort of built around that. What was that person's role once it was established that they were a key component of creating a bigger group? Or like actually like establishing a group, or that this was like something that needed to be created?
Like we just joined the lab last year, but I believe how it started is that the group is called CRAB, which is the Canadian Retinoblastoma Advisory Board, and Ivana and Dr. Damaris are like co-leading that currently.
To my knowledge, Ivana has a child who was diagnosed with retinoblastoma, and when she explains her story, she says that she had a lot of questions about care, and that led her to attend some events that the Damaris lab and like Galley lab and stuff were doing, different retinoblastoma labs. And that is how she got involved and connected, and that her role just really grew until she ended up becoming like a paid staff member on the team. Does that answer your question?
Yeah, that's cool. I like that. Yeah, it also, I'm sure at that point on the journey, that one particular person would probably have different types of advice for people who are newly diagnosed. And so I'm just trying to like map out what this looks like in real time, that I feel like in a type of advisory board that's like this, there would be camaraderie with different levels of experience and different sort of steps on the journey. So that if someone's new and coming in and they're slightly terrified, there is that are more experienced with different things that they can support with. Well, like that. Okay. So this is where we're at right now with our community steering committee. So the steering committee, we'll get into that, I guess, in the second part, but CDP seeks to strengthen its collaborations with affected communities and civil society to identify new research priorities and inform policymakers, stakeholders, and the general public on pressing issues surrounding substance use and drug policy. In recognition of the need to formalize community involvement in our organization's activities, we collaborated with establishing a community steering committee in April of 2023, together with community advisors. We call it a CSC just because community steering committee is like a whole mouthful. The CDPE aims to engage and elevate the voices of individuals with lived and living experience of drug use to guide effective evidence-based policy responses to substance use disorders in Canada. The CSC is composed of 15 individuals with lived and or living experience of drug use from across Canada, and has a mandate to provide expert guidance on CDPE strategic priorities and its research activities. The CSC is diverse and inclusive, representing 10 plus national organizations led by community advisors, various gender identities, geographical locations, and a range of ethnic backgrounds. the CSC meets quarterly as a group, while individual members are embedded within specific projects across a wide range of activities. So as Priscilla had asked, like, how was that established or where they would go? And I put together a questionnaire for people to prioritize what their interests were, and that's how they got paired. It wasn't just like, okay, like alphabetical, like people with like A to C go here. We really wanted to make sure that there was an alignment with people's interests and the projects and programs and the work that we're currently doing. CSC members are financially compensated for their participation in the projects, and meetings are held using a hybrid model of virtual and in-person. Tends to be more virtual than it does in person. We also meet, I mean, the other thing too is that if we're putting in grants that will impact or will have an impact on our steering committee, we'll call a meeting together and have a conversation with them about what we're thinking and get input from them at that point. Like, is this direction reasonable? Does this feel like something that everybody, you know, at the table is in alignment? Or is there anything that we're missing? And we'll have, so it's the quarterly meetings, but we also meet sometimes ad hoc if there's things that we have to do or if there's things that we want input into. So presently our research assistants are located within community health centers, CHCs within the Toronto region, being located within spaces where people who use drugs come to access services and feel comfortable is very important for engagement. So at all of the sites that we are conducting research, we also have partnerships and REB. So this is a great way. We already have an established relationship, and our research assistants are already in these spaces every day, doing research with the population already. Some of our respondents have been engaged since 2018, so it's almost 2024. So some people that are part of our TDOT study, for example, have been part of the study for 6 years. So like if you've known someone for 6 years, you have a pretty good rapport with them. I think, you know, it's that question of like, when is it appropriate to bring these things up in a relationship? I think, you know, some people who've been engaged with us for so long, like they have a really open dynamic with our research. Or in some cases, I've known some of these folks since like 2010. So like, it wouldn't be strange for me to ask them a question about like something that's quite personal, even if I run into them on the street. So I think it's about like timing and what your rapport is with someone and when to ask those difficult questions. The lives of individuals we do research with are complex, multidimensional, and ever-changing. Given the marginalization and levels of poverty, rates to loss to follow-up are really, really high. Given individuals do not have access to steady IT, so cell phones, tablets, laptops, and remaining in touch can be quite challenging. So like the term here is that folks are technology marginalized, meaning that like they're living off of, you know, $300 to $500 a month, that a new phone or a tablet or whatnot is generally not a priority for a lot of people. And lots of people will get a phone or a tablet or a laptop, and like they'll be in a space where they're not doing great and they need to trade it for money so they can sit. I don't know if people have looked around, but like one thing I always do when I'm walking around is I always look to see like where payphones actually still are in the city. And they're very few and far between. Like I think in subway stations are where phones are. And, you know, this is something that is important for people that are outside, who are houseless and who do not have technology, especially people who are using toxic drugs, is that like, you know, they might be with someone, like say Priscilla and I are outside and we're using, and I have an overdose. If there's nowhere for Priscilla to call 911, then Priscilla's left to respond in the best way that she knows how. So these are things that I think the general population don't take into account, is something as simple as like a payphone. So for us to reach people can be really, really challenging if you know, their phone number changes like 20 times in a year and we don't know what that Email can sometimes be a little bit better, like people, I find, you know, you have one email, you kind of keep it the same. Sometimes we can get traction that way too. Another factor for us is we are 8 years into the overdose / drug poisoning epidemic with no government plan. So of all the epidemics that have happened in human history, the overdose is the one that there is actually no government backed plan of how we're going to get ourselves out of this situation. Presently, 21 people die a day in Canada from an overdose or drug poisoning. Many of our respondents have died from fatal overdoses, drug poisonings, and incidents related to fatalities. 21 people a day is a lot. I know even when COVID was like as rampant as it was, there weren't, I don't even think there were 20. So, and you saw the response that COVID got versus the response that we're getting from our government around drug poisoning. Phone call reminders, emails, engagement with staff from community organizations and CHCs are incredibly helpful. Where we can, we will ask our medical supports to put reminder notes into people's charts. If we're connected in that way, so Safe Supply, we are connected. Folks that are on the IO program, we're connected in that way where we can put a note in the chart.
Question about that.
Yeah, in-person engagement are all strategies to remain connected. Sometimes you'll like see someone on the street that you haven't seen in a long time. You can just like stop them and say, "Hey, you're due. When can I see you? Like, when can we make this happen?"
Yeah. So the notes on the chart is something that we've been thinking about, and it was asked it when I presented our rounds as well for kids. Like flag something in the charts to say like, exposure. But I feel like it's so stigmatized. Like I feel like depending on who's from, it's so stigmatizing for the family. So do you find
That's a different type of, that's a different type of thing. So what we can do, this is specifically for if the person is due for their next survey versus like flagging in someone's chart, because like I've done lots of documenting and charting over time, and I respect the challenges of putting particular things with particular language in there. Once you put something in a chart, it's there forever.
Yeah.
So I'm not a lawyer, so I would not be the best person to advise you on that, but I'm sure that there's someone in the broader circle that can advise you on that. Yeah. This is strictly to like, this is around like engagement from the community and how we can minimize like people that are lost to follow up who are really trans. Yeah. And financial compensation. So folks get $30 per survey, and then we also do a checkup or like a check-in for the TDOT survey specifically. So lots of times people will check in and go like, "Hey, when am I due for my survey next?" And if it's only at month 4, we'll still check in with them. We'll tell them when to come back, and they'll get $10. So another way to keep connected. Okay, other question, and we've started to sort of like talk about this, I think, already. How do you engage community partners in the work? Or what are some ideas, thoughts, strategies that you've already mentioned, sort of what your journey was like and how you reached out, time, the challenges, those things?
Pediatric Society or Provincial Council for Maternal and Child Health. So a little bit higher up, but still trying to service. They have access maybe more to like
I think in terms of how we actually engage our partners in the research that we're doing is we sat down and had a virtual roundtable discussion, talking about our lab that they were already familiar with, and we thought it was going to go in one direction, but we learned from their questions about what they were actually curious about in our research, and we talked about different tasks and roles that they were interested in. And then it kind of was like a collaborative plan together about thinking about who's interested in doing what within research.
Mm-hmm.
That is on track.
Yep. Yeah, so you went into a meeting thinking it was going to go, or thinking that you were going to materialize with like X, and you materialized with Y, and it was different from what you were thinking. And then but I mean, what I appreciate is that you were able to integrate that knowledge and sort of pivot your direction moving forward. Yeah. Yeah, I agree. I think, again, same thing when I looked at pairing people, for example, with our projects, like I wouldn't want to pair somebody with something that they're not interested in. I think same thing goes from, what I'm hearing you say is that you aren't going to want to partner in a way that's not meaningful or where the level of engagement isn't coming in on both sides of the table. So that's great. Yeah.
My PhD work, which was at a university, I was seeking to recruit youth with lived experience of health and mental health conditions and found it really useful, like similar to what we've been talking about, the relationship building piece. So approaching different groups and describing my intent and like the reasons why I was planning to engage, sharing a bit about my background and story to, I think, illustrate where that was coming from. And I've also found like social media to be a really helpful way to connect with different groups. That's how I've started a lot of connections, and then I'll get on phone calls or Zoom calls and we'll find shared interests. And I found for recruitment purposes, you can then share and retweet, and there's like great credibility and great connections in these existing organizations. So there's all these different like ways and strategies. But I find getting in front of people and describing, like we talked about, what's the intent? Why are you planning to do this? Exactly.
Yeah.
Where's that coming from? That can go a long way.
Yeah, 100%. Yeah, I think intentionality and being incredibly genuine about the why is very important. And as I said to you before, like folks in my community setting, like if you're not being, they will not. And same with youth, right? Like youth have a different kind of sort of way of relating, and the way that you need to present things to them is also a little bit different than like an adult population or like a 65 plus population. Like it's going to be different, and same with the way that you would, I think, about information sharing. For example, like visually what you would share with someone who's a youth is probably going to maybe be different than what you would share with us, or how you share it, right? Like with the youth, you can text them something and you know that they've like digested it in 1 minute. Whereas like if it's someone that's like 65 plus, for example, like you might be picking up the phone and having a phone call and then be texting them this particular visual. So yeah, there's a difference there too. Okay, so community partners and a research lens. So we are currently meeting with our partners quarterly to update, formally speaking, email updates when there are things to update sort of in between meetings individually, regular communications to check in on how projects are happening in community spaces. I will also say, like, I do a bi-weekly audit at all of our sites. So I'm actually like dropping in, and I usually will message like a few people at each of those spaces because they're people that I've been working with. And I'll just say like, hey, I'm dropping into a coffee, right? So I think there's also value sometimes. Those informal meetings, I will receive an abundance of like download of information than if it were a formal sit down meeting with someone. So I think where you can create space to have those informal check-ins is actually really helpful. And it's not always possible. It's like one of my gripes that I wish I had more time to be in community with people. The other thing is peer review and peer co-authorship opportunities. I think this is very, very important, both from a community steering committee perspective, but also a community partner perspective, like especially when it comes down to service provision. Researchers, I don't want to say always, but are generally not on the service delivery side. So there is a bit of a gap between sort of what that looks like. And so it's been very helpful to have peer co-authorship for that reason too. And then, yeah, as I say at the bottom, when I'm out in the community bi-weekly, I end up seeing a whole bunch of people that I check in with informally. And I also see community, so it also gives like a bit of a pulse for me to check in and see how people are doing. which actually changes seasonally, right? Because people could be doing fantastic when you see them in the summer and then you see them in the winter. It's like a whole different kind of scope of how things are going. Okay, this is a question around compensation. You're on a budget and approaching community for research purposes. What are some strategies and ideas you can leverage to best engage with your target population in an ethical manner?
So I like personally, I feel we need to be compensating financially. Like that's to me a non-negotiable.
Yeah.
I've worked in spaces where, and so that might mean making concessions in other ways. In terms of budgeting, applying for, accelerator funds, other pots of money, if that's possible. I've again worked with youth and also asked them, like, in addition to financial, what other things might be helpful for you at this stage of your life. And sometimes there are other ways, mentorship, networking opportunities, reference letters that we can use to supplement. But I feel it's a non-negotiable. So it's tough if you're in a budget and you're constrained. Like, is it more ethical to not go that? I don't know. It's a bit of a dilemma.
Yeah.
I don't know the answer.
I was going to elaborate on that. The networking opportunities where you like maybe host monthly events, or like if it's the beginning of your research project or like whatever you're doing for research purpose, a networking session that's well advertised on social media. Because those one like sessions wouldn't be too much. Like you could like order like food, and it'll be like a group setting where the main purpose is like you're still compensating with like nice lunch, but also learning, bringing the community together. Like a pizza thing.
A community lunch type thing, or like a lunch and learn sort of experience.
Yeah, lab, so. These groups have are very
Any other thoughts? It's tricky. It's so tricky. I have one example of which I'll share that I thought was really phenomenal of someone that was their PhD. So how do we compensate for both survey and for the community steering committee? So the community steering committee is paid out a $30 honorarium for any and all work. So meetings, review, authorship, like across the board. It was 25, and then the issue was raised of like we should be getting compensated in the same way as RAs. And we said, oh yeah, maybe you should, like, let's do 35. All study respondents are compensated $30 per interview. As I mentioned previously, TDOT study respondents are offered a $10 check-in between interviews. This check-in is generally utilized to check when the respondent is due for their follow-up. We're always open to feedback from the community we work in around compensation and any changes. One of the things that we've talked about recently is, at each of our sites, do we want to have like a snack cabinet where there's like food and beverages? If it's summer, do we want to have like Gatorade? If it's winter, do we want to like get a carafe of coffee? What other things would we want for snacks when they come in? So those are things that we're looking to have at our spaces, because most of our people are coming in hungry and our surveys are an hour long. So if people are hungry, like just their engagement isn't going to be as great as if like we had a student get something to drink. And then my PhD student on a budget. So this was a person that I knew, and they were doing their PhD, and their their final was a photo project, and they were very upfront, said like, I don't have a huge budget, this is coming out of my pocket, like I am not funded. They needed to do 3 interviews, so pre, post, and then they wanted to do like a final sort of closure interview with each person. So it was 3 people. So again, it was a very, very, very small project for their PhD. It was a photo project. So they gave each person a disposable camera, a really nice journal with a nice pen, some pencil crayons, $20 cash at the first interview. And then the second interview, they got the camera back for developing, and they had some more questions, and that was compensated with cash. But they also brought like snacks and those types of things to that second. And then the third was also compensated with $20 cash and a copy of their photos. So I think there are ways, like I'm with you on the fact that I feel like there should be financial compensation anytime that we're asking people from the community to share their expertise with us. Whether it be through research or whether it be for doing like a community steering committee, I feel like there should be acknowledgement. I think living wage in downtown Toronto is like $25.50, which isn't even like our minimum wage. So I do take that into account also, but I think if you're willing to come to the table with something like cash and something, I think that goes a long way. And as you said, maybe you don't go as grand, like maybe you do groups instead of like individual, or maybe reducing how many people you take in. I think there are different strategies, but still paying people is very important.
Your CSC honorarium, the $30,
Yeah.
is that informed by provincial rates and guidelines, institutional rates, or was that something that your group decided on based on their own funding? In consultation with the CSC members?
I don't know where the 25 came in. So like when I started, I came in and I inherited like a very, 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 very new community steering committee. And that was sort of, I'm not sure where that original number came in, but when we had met with the CSC, not in June, another time, the community steering committee brought up to us that they felt that they should be compensated in the same way that a research assistant was compensated. And so that we figured, because it's an honoraria, folks aren't getting taxed on it, they don't have benefits. We went like in the middle of what a RA would be compensated for. But I don't know where the origin of 25 had started. Maybe that came from like a living wage perspective, was maybe where we had started looking at that. And then we looked at, well, what is compensation for someone doing this job? Same thing. Yeah, but we didn't look at anything particular like regional or like, I don't know that there are. Something for me to maybe take away and go actually look at, like, what is compensation for people who've lived in living experience, or is there like a standard for what people are paid for research?
CIHR has guidelines, SPIN has guidelines, SCORE has guidelines, dependent on the province. Institutionally, there are guidelines into universities, hospital settings. I'm curious
Where specifically?
that came from.
Yeah.
And where it aligns federally, provincially, or institutionally.
Mm-hmm. Okay. Yeah, I'll take it away and dig around. But yeah, the amount for the steering committee, so that I think is research side of things, but for the steering committee, that was something that they had identified, that the work that they were doing was similar to an RA. Yeah. Time it is, but still have time if anybody has questions. Yeah.
I have a question, but it's kind of moving away from the patient engagement piece a little bit, the community
Yeah.
engagement, just from the analysis qualitative analysis that was sent out beforehand. I was wondering how your translation piece works from that into any policy or operational changes of safe injection sites or safe
supply.
safe supply.
You're talking about the safe supply and the COVID-19
Yes,
paper.
yes, because one of the takeaways was that people who are injecting opioids are still going through withdrawal from the doses that they're getting from Safe Supply across Canada or different sites that are similar to Safe Supply.
Yeah.
So I was wondering if or how that actually impacts the operations of Safe Supply or associated sites and what you're legally allowed to do in order to accommodate that or try and stop people from going to withdrawal.
So I don't think I can answer that because I think that's such a much bigger question around, like, it's a government question and I'm not government, so I'm not comfortable responding on their behalf. But I can tell you that when SUAP made its last funding announcement at the same time that they made the announcement for the drug checking funding, they did share that they're aware that Safe Supply funding needs to continue, but they're also wanting to address questions around diversion. So I know that they're currently looking into diversion right now with all the different programs. And I think looking at withdrawal is one of those pieces. I also think people who are, and this is my personal experience working in Safe Supply, that people who are using fentanyl should be treated with fentanyl, but it's not covered. It's the only thing that's covered in our province right now is fentanyl patches, which to adequately compensate someone's use of street supply, they would be walking out of like pharmacy looking like a sticker book with how many fentanyl patches they would need. So like things like Ventura are not covered. So any fentanyl that could be prescribed would have to be paid out of pocket for people. So I think that's another aspect of it too, is that we don't have fentanyl programs in Toronto. Like Vancouver has fentanyl programs like Dr. Sutherland or Christie is running and has been running quite successfully a fentanyl program for well over 2 years. And that's she does that in 2 different ways. One of them is pay out of pocket. So some people come in and they pay out of pocket for their fentanyl, and then there are other people who are specifically on their fentanyl program. We don't have that in Toronto. And our province is very different than the BC government around. So like, I think there's 2 pieces to look at within the question for me anyways. One of them is, do the medications even compensate or even like hit what people's tolerance levels are? And the answer is no, and I can tell you that. The other question is like, that I think is being raised is like, what's happening in terms of people diverting medication? I think it's like a broader question. I know most people who are on Safe Supply, that yeah, there's different theories around that. So, but I ultimately think we need better drugs. So.
Like OET, so it's covered if like you're a recipient of ODB, but are there a lot of like can you go to stage C and get OET for free, or you people have to pay? Because I feel like that should be.
Are you talking about IO or O?
Oh.
So O's covered.
But only if you're ODB, or you have, like, only if you have ODB. It's not just for anyone, right?
Should be covered for anyone.
Sometimes I was told that it wasn't, and then I was going on this like, digging around trying to figure it out, and I was told it's not.
Methadone, Oxone.
Yeah, like it's covered if you're in ODB, but if you're not in ODB and you don't have private insurance, you would have to pay in pocket.
What about Trillium?
So that goes under ODB.
Yeah, but if somebody's not covered by ODB, then you could get them Trillium coverage.
So,
And then if we're talking about like like I'm thinking also streams for refugees, you might be able to get that covered at CHC because CHCs do have budgets for medications for folks that refugees. It should be covered though. Like I feel like there's enough, like there's different ways to get it covered. So if it's not ODB, and the person's not on ODSP or OW, then it would be going through the loophole of Trillium Health, which does sometimes take a while to get the application in, but that would be my personal next step. And if it was someone who was refugee, I would go through a CHC and see if I could get it covered that way. Yeah, but anybody that I've ever had that wasn't on ODB, or let's say they were on insurance and then they were no longer on insurance, we've applied for Trillium. Yeah, and I think the difference is the difference in financial coverage between OAT, which is like Suboxone, methadone, sometimes Cadian, depending on who the prescriber is, and IOT, so the injectable hydromorphone, like the program at the works, is not covered by ODB. That's currently funded through SUAP. Mm-hmm.
there would be no record of any of that done in data. Because it's probably through like a special access program, right?
Yes. Yeah, but it would be, you probably, I mean, SUAP is gonna have the data for it and the works would have the data for it, which is public health, so there's gotta be a record of it. You should ask, I mean, I can follow up and ask, because it's a good question.
Well, I've gone through like, I've tried to figure out a bunch of it, because also, W-Tex. The mono one. Like Suboxone's and naloxone in it, and there's W-Tex, which is just straight buprenorphine.
Mhm.
So that's available through special access program. We can't, have records of it in the CVS because it's literally like dispensed through a physician. It doesn't actually go through a pharmacy, so it doesn't go through a pharmacy.
I wonder though about public health record. Same thing. Given that it's coming from a public health service.
HC data.
Now I'm wondering too, like, yeah, I feel like there's got to be a record of it, like in terms of a program. I mean, if you're providing, like a narcotic, there's got to be a record.
Yeah, well, like Health
Dispensing it.
Canada would have records of all.
Yeah, but even on a program level, like if you're dispensing, like they're dispensing as a program. So I think if you're dispensing, there needs to be a record. Like legally, there needs to be a record.
Yeah.
That would be the question.
Are there any other questions either online or in person for our speaker? See someone's typing, so I'll just give them a moment to do so. Question I have for you, Jolene, is what advice do you have for trainees or researchers as a whole who are thinking about entering in the space of working with populations very much that we've worked with in the past, who are vulnerable, hard to reach? I know you mentioned there's different strategies to reach out, email being one of them, potentially social media, going straight to community organizations. Where do you kind of suggest folks kind of start if they were a roadmap to doing this work?
To doing the work or to finding people in the community? Because those are two different things for me.
Let's tackle both.
Okay.
I think they're both important.
I think people locating is a special skill. I think from a research perspective versus like a service provision question, I would have two different answers for you. So if I'm trying to locate someone from like a service provision, I think that I have different ways in which I can find people. From stopping in at community locations to going to their pharmacy and leaving a note and leaving tokens has worked really well. That's from a service provision standpoint. I think from like a research standpoint, you can do the same thing. You can still leave a note, you can leave tokens, you can ask around to see who the person is, I think. I think again, also from a service provision perspective, and I think for research is actually just showing up and being, people will know, like if you show up kind of week after week, it's the same time, it's routine, like people who kind of come to expect, like I'm gonna see Priscilla, she's gonna be at like the center from 2 o'clock till 5 o'clock every Tuesday. Like I can just go show up and she'll be there, you know? People can remember that, or people will start to remember that. Whereas like you aren't there, you don't show up, you show up sometimes like from 1 till 3, you know, like if there's not consistency. So that's that one piece around like, how do you stay connected? But there was another part to your question. One was around locating people and staying connected.
This wasn't part of my first question, but your answer is probing me to it, is retention.
Mm-hmm.
You know, what strategies are you utilizing to retain those that you're recruiting onto these projects, given the transient nature and the vulnerability associated with just the group as a whole?
Yeah. So there's the things that I've mentioned already. So phone calls, emails, leaving messages at like the original place where we've interviewed them. Where we're able to, we can also leave like a message in their chart with their provider to say that they're due to see us come by on Tuesday or Wednesday or whatever day it is that we're there. We also have a partnership agreement with the coroner's office. So I'm just preparing a list for the coroner to check if those folks are deceased or not. So I think, again, this is like one of the challenges that the population that we're working with is using a toxic supply of drugs, and at 21 people a day dying, we, you know, lots of times we'll get wind or people will tell us of certain people who've passed in the communities. But that's another thing that we're looking into is coroner data. Yeah.
I'll do one more sweep. Are there any questions for our speaker at all? Either in person or online? Stop. If that's the case, I want to thank our speaker, of course, Jolene, for coming and joining us today at the Trainee Hub, and yourselves, of course, for attending. This is our last event for 2023, so please stay tuned for the announcement in January in our newsletter about the upcoming events for winter and spring. For everyone online, in person, have yourselves a wonderful rest of the day, as well as a great holiday, and I look forward to seeing you next year. Thank you.